Hello, my name is Nicole Linkous, and my capstone project is about modeling infectious disease transmission in Southwest Virginia using electronic medical records. Influenza is a highly contagious respiratory illness that primarily spreads by tiny droplets in the air that are produced when an infected person coughs, sneezes, or talks. The CDC estimates that on average, about 8% of the US population gets sick from the flu each season, impacting school attendance, worker absenteeism, and daily productivity. As part of a multi-year project in partnership with Carilion Clinic, under the mentorship of Maddie Tenzer and E.L. Kaufis, this project seeks to improve our understanding of the features in electronic medical records that are most effective in modeling the transmission of infectious diseases. The insights gained from this work could eventually lead to earlier detection and interventions, reducing disease spread, and equipping public health officials to manage and prevent outbreaks. Electronic medical records, or EMRs, are a digital version of a patient's medical chart. This data generally includes information about patient demographics, encounters, diagnoses, medications, and more. EMR data is vast and high-dimensional, and the data can lose its meaning if this dimensionality is not reduced. Feature engineering is a critical step in simplifying complex EMR data to prepare it for machine learning and improve model performance. This is an overview of the data pipeline, which operates entirely within a cloud-based, HIPAA-compliant secure research environment to ensure data security and patient privacy. The beginning of the pipeline is independently managed by Carilion Clinic's Health Analytics Research Team, also known as HART, to ensure data quality and adhere to the data security principle of least privilege. HART extracts the relevant data from the EMR system, exports the data to CSV files, and stores the files in a central repository. Next, each raw data component is cleaned and transformed. Upon completion of all data processing, the data sources are compiled into one unified dataset. Two advanced feature engineering methods are then assessed for their efficacy in optimizing EMR data for machine learning. The dataset is transformed separately by each of the two feature engineering methods to remove noisy and irrelevant features and enhance the accuracy and precision of the models. The first method applied to the dataset is dimensionality reduction using principal component analysis, which reduces the number of features without losing the important information in the data. The second method applied to the dataset is feature selection using XGBoost feature importance scores. This approach simplifies the EMR data by selecting the most important features for predicting infection outcomes. Multivariate logistic regression is then applied to each feature-transformed dataset. This is used to predict infection status by examining multiple factors at once. Finally, the performance of the two models is assessed using a combination of metrics that explain their effectiveness. This includes the receiver operating characteristic curves and area under the curve scores to gauge model accuracy, as well as precision, recall, and F1 scores, which show how precisely the models can identify infections and how many true infections they can correctly detect out of all cases. Let's discuss the top 5 results and outcomes of this research. Comparing the performance of each model, we see that both have similar area under the curve values. This means that they're equally good at predicting infection outcomes, much better than simply guessing at random. Essentially, both models are proficient at determining who might be at risk of infection based on the data. You'll notice that the area under the curve for the PCA-based model, highlighted in green, is slightly higher, which may mean that PCA is capturing more useful information or variance in this specific use case. The models are effective at detecting true infections, but they also have a tendency to mistakenly flag non-infections as infections, leading to a number of false alarms. The low F1 scores for each model indicate a need for improved accuracy in distinguishing positive outcomes from negatives. Dimensionality reduction with PCA simplified the complexity of the EMR data. From the original 53 features, PCA reduced the dataset to just 6 principal components. These components efficiently blend the original features, preserving the important information in a simplified structure. These 6 components retain enough information to create an effective model, capturing about 65% of the information found in the original dataset. This plot illustrates how much cumulative variance is preserved by each of the principal components. Feature selection using XGBoost was applied to sort through the EMR data to determine which information may be useful for identifying flu infection outcomes. This process narrowed the original set of 53 features down to 9 key features based on their importance scores. The primary features include a hospital visit within the last year, record of receiving a flu vaccine during the flu season, insurance group ID, suggesting healthcare access and possibly employer details, as well as the individual's birth date. These features were selected by focusing on those with importance scores above the average. Due to the preliminary nature of this analysis, further investigation will be necessary to fully understand the implications and assess the reliability of these results in predicting infections. The project also catalyzed innovation within Carilion Clinic's cloud-based secure research environment. Responding to the intense computational demands of this project, the organization proactively developed new servers equipped with more robust computational resources. I was among the first to test the upgraded environment, which is set to significantly advance Carillion's research efforts. Great progress has been made in the second phase of this multi-year project, but the journey is far from over. Looking forward, the next steps will include clustering analysis, deep learning, and building more generalizable models. Clustering analysis may further our understanding of disease spread through community connectivity by grouping patients into broader categories. Deep learning will elevate the research with cutting-edge analytical methods, potentially offering more profound insights. Expanding the research scope to include additional illnesses and seasonal contexts may improve the generalizability of the predictive models. This phase of the project established a pipeline for refining complex EMR data, provided foundational insights into key EMR indicators of infection, and it has also played a role in driving the innovation of our research infrastructure. The next phase of this research will be led by another DAME student beginning this summer. I would now like to open the floor for questions.